Ontario Kinesiology Association. And we are welcome to this webinar and current evidence on low back pain management. This webinar is being recorded and will be uploaded to Keen in approximately 2 weeks. There will be a question and answer period at the end of the presentation. For any questions, we ask that you enter them in the question and answer function so that they can be addressed at the end. I am pleased to introduce our presenter this evening. Samuel Silva is a PhD candidate in epidemiology and applied health research at Dalhousie University and a member of the Back Pain Evidence Synthesis and Translation Program, or BAC program. He is a trained physiotherapist and holds a master's in rehabilitation sciences. With experience in evidence synthesis within the low back pain field, his current research focuses on how to better implement exercise treatments for patients with chronic low back pain. Please join me in welcoming Samuel this evening.
Thanks, Nicole, for the introduction. And yeah, thanks for having me. I'm very happy to be talking to you. And yeah, so I guess my idea here is to give you guys an overview of the current literature on low back pain management. So yeah, just to start off, I wanted to kind of, share a few fun facts about where I am from in Brazil. Just yeah, to kind of break the ice and so I don't know if you know, but Brazil is the is the greatest coffee exporter worldwide. And Minas Gerais, which is the state I am from in Brazil, is the greatest coffee producer in Brazil. And my hometown, which is a very small town in the south of Minas Gerais, is the greatest producer of coffee in Minas Gerais. So it's just, yeah, something that I think a lot about when here in Canada, because, I believe Brazil sells a lot of coffee to Canada, so I keep thinking, that people might have drunk, you know, coffee from, my hometown, which, I don't know, I just like to think about that sometimes. It's a very small town in Brazil, and yeah, and I assume a lot of people here like coffee. And yeah, and so I moved to the capital of my state, which is called Belo Horizonte. It's the third largest city in Brazil. It's where I did my undergrad, my master's. So on the bottom left, it's just a picture of the university that I graduated from, the UFMG. It's one of the main universities in Brazil. Belo Horizonte, so the capital of Minas Gerais, is a beautiful city. We also have some, beautiful Christmas lights over there during Christmas time. So this is a picture of a very popular place there. It's called, I think, like Freedom Square. Yeah, I think that would be the translation. So anyway, very nice place. I think, bottom right. It's a picture that I think represents pretty well my state there because it just I think you can see we have thousands of waterfalls like this one. Anyway, in the middle, just a picture of myself, a patient, a colleague when I used to practice as a physio over there. Okay, yeah, let's get started. So my idea here is to cover a bit of, diagnosis, prognosis, and management of low back pain. So I'm gonna emphasize, exercise treatments, but we're gonna talk a bit about pain education as well. And then at the end, I'm gonna go through some tips for communicating with patients. And this is from a paper that very recently published. Yeah, I think it'd be useful to include in this presentation. Okay, so low back pain is a huge problem worldwide. So all the countries that are in purple are countries where low back pain is the main reason for of years lived with disability. So the leading cause of disability. So Canada is one of them, the US, most countries in South America, uh, Europe. So it's a huge problem worldwide, and it's a highly prevalent condition. Its prevalence has been increasing, and it's gonna keep increasing in the next years. So yeah, uh, and when we talk about low back pain, we have these three buckets that we classify patients into. So from bottom up, we have low back pain cases where the low back pain is caused by a kind of serious pathology, a spinal pathology. So the main examples are fractures, cancer, Cauda-Equina syndrome, infection, fracture by far the most common among those. So it's a very small proportion of people who have low back pain who, have pain due to, uh, any of those pathologies. And then you have another quite small proportion of people who have low back pain due to some radicular syndrome. So, which means that, it's usually low back pain related to some disc herniation. So it's low back pain that comes with some neurological symptoms as well. So, pain that goes down to one leg and, some other, neurological symptoms such as, motor weakness, loss of sensation. And then we have this big bucket. So 90% of people who have low back pain, we, label them as having non-specific low back pain. And which is basically, when we cannot, uh, oh, okay. Thank you. But so yeah, so it's basically low back pain where we cannot, identify a cause, right? That we cannot clearly identify a underlying pathology. So it's also known as mechanical low back pain as well. And I'm gonna focus on this type and this category of low back pain in my presentation. Yeah, so I think one thing that it's something it's important to talk about is the issue with imaging. So imaging is a big issue in our field, especially because in most cases it can cause more harm, uh, more harm than good. So yeah, it's important to acknowledge that imaging findings don't correlate well with the patient's symptoms. This based on what the literature has shown us. So so look at this table, for example. This is from a systematic review that looked at the prevalence of some imaging findings across age groups among people who have no pain, so pain-free individuals. So the generation, for example, it's quite common, among people in their 40s, for example, right? So around 70% of people who have no pain, who have some disc degeneration and some other findings. So this protrusion, so this herniation is quite common as well across all age groups. So the current literature is kind of consistent showing that our spine is actually pretty robust pretty strong and pretty adaptable. And many of those, alterations that, we might see in a scan, might be just, or, it's just our body aging from inside, right? Like just like her gray hair, for example. And imaging for, when patients with non-specific low back pain who have no signs of having a serious pathology, if they undergo MRI, they actually experience worse outcomes in the long term. So we have, some studies showing that they experience greater disability in the long term. They, have more medical spendings, mostly associated with medication and even surgery. So, this can lead to a whole cycle of, over diagnosis and over treatment. So it's quite a, important issue in your field. So, I strongly discourage to ask patients who have specific low back pain, no signs of having serious pathology to undergo, a scan. And good news, is that this herniation, although, they seem serious, right? And they can be quite disabling. But the reality is that, they usually have a positive prognosis. So most these herniations will be, naturally reobserved, usually around 6 months. And, with conservative treatment. So, it's something that, it can cause, symptoms, can be symptomatic, of course, can be a cause of radicular symptoms, but even in those cases when we, suspect that the patient might have a disc herniation, early imaging may not be helpful. Uh, and yeah, and again, the prognosis is usually positive. So, okay, so when imaging is required, when, it's helpful to undergo, an MRI or an X-ray. So it's, again, when we suspect that the patient has, some kind of severe pathology. But the problem is that, what is enough risk, right? So how, you know uh, uh, what we should use, what characteristics are better, indicators that the patient might have a severe pathology. The short answer is that we don't know, but, there's some work in progress that, hopefully soon enough will provide, uh, a useful tool that providers can use to help them make this judgment more objectively. So the idea is that, and this is a study that, is being led by our team, and, and my supervisor is the first author, Dr. Hayden. So soon, there'll be a tool out there that will have providers, kind of estimate the risk of patient of the of patients of having, a severe pathology, and then make a judgment based on that. But meanwhile, I think a very good resource we have is this kind of framework that was published a couple of years ago, I think 2020. And, they basically present some symptoms, a list of symptoms that, that we call red flags, some signs, symptoms, and also some patient characteristics that, might indicate that the patient might have a serious pathology. And the overall idea of this framework is that like these symptoms in isolation, they don't provide, they're not that informative. They don't provide, too much useful information, and they kind of help make this judgment, about, if the patient, whether the patient has, a lower or higher his or risk based on the combination of some of those, symptoms. So, for example, a patient, an older patient who has osteoporosis, a history of falls, and maybe he started feeling, back pain after they fell down. So, okay, this might indicate that this patient might have a fracture, right? So, imaging might be indicated in this case. And yeah, so I think this I highly recommend the reading of this paper. Uh, okay, and let's talk about prognosis. So the good news is that uh, acute low back pain cases have, a very positive prognosis in general. So around 70% around 70% of acute low back pain cases will resolve within 3 months. So 35% within 1 month. 35% will take a little bit longer, but will resolve within 3 months. And then we have these 30% who will develop chronic low back pain, which means that the low back pain will persist for 3 months or longer. And I think it's important to mention that there are different types of chronic pain. Uh, I think a common misconception is to think of chronic pain as, a constant level of pain, throughout the day, throughout the days and weeks and so on. And it's not always the case. So, some recent studies have, look, at that more closely. So, different types and patterns of chronic pain and how this could inform, the prognosis of these patients and management. And this study, for example, they found like 16 different types of low back pain trajectory. So you can have someone with, very mild baseline pain that is, constant over time, but you can have people who have, a higher, baseline pain, but a lot of flare-ups throughout the week, and, have all these different types. And I think it's important to keep this in mind, because I think this could be useful for management, especially because, if you think, for example, this person with, very mild pain, but, some occasional flare-ups might require, might benefit more from a strong self-management plan, and maybe someone, with this, pattern of pain, with a lot of fluctuations, a higher baseline, higher level of baseline pain might benefit more from, a closer follow-up, more sessions, and, a closer follow-up. And also, it's important to mention that there are factors that, that may, when they're present, they may delay recovery from like low back pain. We call these factors prognostic factors, right? So some examples that, have been identified in the literature are poor sleep, for example. So, patients who have low back pain and also don't sleep well, they are less likely to recover from low back pain. They will take longer to recover. So patients with fear of movement, for example, kinesiophobia, right? So people who think that, movement is not safe, they usually tend to have stronger preferences toward more passive types of treatment. And yeah, it's not a good indicator for their prognosis. People with negative expectations about the treatment and also about their condition, so people who think, they won't get better no matter what they do, they usually do worse. And also people, uh, who suffer some kind of psychological distress, such as depression, anxiety, and also people with high physical demands at work may take longer to recover. So people who have, to do a lot of manual work, for example. So these are some important factors, that, it's important to be targeted, during treatment in order to maximize the effect of, the whole treatment program. Okay, so let's talk about management, how to manage low back pain. This is a very nice review that I highly recommend the reading as well. It's a systematic review that was published last year, and they basically included only high quality clinical practice guidelines. So they had, some criteria. So there's a tool, it's called Agree. So it's a tool that you use to assess the quality of clinical practice guidelines. So they only included the high quality ones, and they kind of summarize what those guidelines agree on, and what is consistent across these guidelines. So in terms of acute low back pain, we see that, for example, advice to stay active and patient education are, interventions that are consistently and strongly recommended across most guidelines. Exercise therapy is also consistently recommended, but usually, guidelines we recommend, exercise therapy, exercise programs, uh, with some, conditions. So, depending on the patient. And this is especially because, like I mentioned, acute low back pain has usually a very positive prognosis. So no matter what they do, most people will get better, right? So if someone is, if a patient with acute low back pain is, for example, very active already, and they have like positive expectations about the recovery, and they usually will benefit from, just some advice and some support to stay active and, to self-manage their pain. But, for some patients, exercise therapy might be recommended. But when we talk about chronic pain, chronic low back pain, exercise therapy is highly and strongly recommended across, most of the guidelines, patient education as well. So here yoga, also came up. Uh, some papers will treat yoga as, as a type of exercise. In this case, they treated it as a separate intervention. But yeah, so exercise and patient education, should be the core of the, of chronic low back pain management. So let's talk briefly about patient education. I'm not gonna spend too much time on it, but I think it's important to mention a few things. So when we talk about patient education, the context of low back pain, we are mainly talking about pain education, which is basically teaching patients about, about their pain system, right? Like how their pain system works, and of course, in a easy to understand language, And the idea is that by doing this, we are empowering, the patient in a way that they kind of understand what is going on with them, and then, that they could take action and be more active in terms of their management. And, it's an effective intervention, especially for long-term disability. So it's pretty effective in reducing long-term disability in patients with chronic low back pain. And yeah, I just want to mention these two resources that I think are pretty good. So the first one is a textbooks, is the Explain Pain. Very nice, very good textbooks, very informative, very easy to understand language. It was actually written for patients, so it's a resource that we can actually share with patients. Uh, so these are the pain fact sheets. So these are basically, this is something that is freely available on the Pain Revolution website. And the Pain Revolution is a sort of a movement that was created by a leader in pain education research, Latimer Mosley. He's an Australian researcher. He's one of the authors of this book. And yeah, so basically they present some, I think it's like nine facts about pain in a very, again, easy to understand language. And it's a very nice resource. And they have it in, many languages. And I was actually the one who translated the original version into Portuguese. And yeah, so these are two resources that I highly recommend. And yeah, the core idea of pain education is to kind of, communicate this message that, pain is not equal to tissue damage, right? That, it's way more than that. Pain it's not a real and, a true reflection of what is going on in the, in the tissue. And the tricky thing is that, communicating this, that hey, pain's more than, just what is going on in your spine, it's affected by, many other things. Sometimes the tricky part of it is that, many patients can interpret this as, oh, okay, this guy is saying that my pain's not real, you know, he's implying that, it's my pain psychological. So yeah, this can be tricky, to kind of communicate this message in a way that the patient actually understands and, uh, don't think that we're kind of, not believing in him, in them, right? And I think one good way of doing this is, using examples that kind of speak to them. So, for example, asking them if they have noticed, any changes in their symptoms when they are stressed, they don't sleep well. The answer it's usually yes. And so I think it's a nice way to, oh, okay, so you see, it doesn't mean that, something happened to her, to her spine, maybe, nothing happened, but, if your symptoms change, you know, because you're stressed, because you didn't sleep well. So, pain is way more complex than, just what is going on in, in your spine. So yeah, let's talk about exercise now. So like we saw, exercise is highly recommended and, strongly recommended for chronic, especially chronic low back pain. But how effective is exercise? And unfortunately, the reality is that it's not that much. So this Cochrane review that was led by our team. So, more than 200 studies were included, more than 20,000 patients. And one of the main findings was that on average, patients improve 15 points on a scale from 0 to 100 in terms of pain intensity compared to no treatment. So it's pretty small, right? So 15 on a scale from 0 to 100, but it might be the better that we can offer to them based on what we know right now. Uh, and another question that we might have is, oh, okay, so but exercise is such a heterogeneous intervention, so there are so many types of exercise, so there might be some that are more effective than others. So this study led by Dr. Hayden, my supervisor, try to look at that. So it's basically a secondary analysis of, the Cochrane review that I just mentioned. And they use like a network meta-analysis, which is a type of analysis that kind of compare different interventions, even if the individual studies didn't compare them directly. So, they found that some exercise types tend to stand out. So, for example, for pain intensity outcomes, Pilates seem to have, a great effect. Functional restoration exercises, so exercises that, focus on, improving function and, disability, and McKenzie as well. And then we have other ones that, the fact we're not that great. So we're aerobic exercises, stretching exercises, for example, quite similar for functional limitation outcomes. So, Pilates, McKenzie, tended to stand out, and flexibility exercises also came up. So, active mobility exercises, tended to have a greater effect size. But what, the main guidelines actually recommend is that we value the patient's preferences when we are, making this decision about, the exercise type, the exercise approach, especially because the differences are not that substantial between the exercise types, in a way that we can confidently say that, okay, patients with chronic low back pain should receive this type of exercise. And actually, there's kind of a push in your field toward kind of shifting away uh, from this call center approach. So what I mean by that is that, okay, so when we think about an effective treatment for, any condition, so any disease, any health condition, we usually think that an effective treatment is the one that will kind of target the causes of that condition, right? That goes straight to the root, straight to the roots, of that problem. But the issue here is that we are dealing with a condition where, you know, we call it non-specific because we cannot, identify a clear cause for that condition. And, on top of that, it's likely a multifactorial condition, that is affected by biopsychosocial factors. I think this figure illustrates this well. So this is basically a figure that was developed by some experts in the field, and they just, each circle represents a potential cause. of low back pain. So, it's a condition with, likely, several causes, but we're not able to clearly identify them, at least, based on what we know right now. So I think this editorial that was published in 2024, I guess, provides a very good, discussion about this, and, they kind of go through this idea of paradigm shift, which is basically, instead of always trying to find a cause that explains the symptom and then trying to, target those causes, maybe the best approach is to kind of embrace complexity and even, embrace uncertainty, right? And they have this framework that they kind of go through some steps for, prescribing an exercise program for, chronic pain patients. And the idea is that to kind of first identify, activity limitations and participation restrictions, and then based on that, define a shared plan, with the patient to target those limitations and restrictions. And then, the whole treatment plan, the exercise program should focus on that, on those, limitations and restrictions. And then they go on with some, other steps. So, identifying and addressing, for example, unhelpful beliefs and some potential barriers to adherence. So, a common one is, some beliefs around exercise, that exercise, is harmful, that can, make their condition worse, and, so it's important to address these, and also some lifestyle factors that could, affect the effectiveness of the program. So, the prognostic factors that I mentioned, so sleep, stress, so all those lifestyle factors, are important to be addressed in the treatment program of these for these patients, and then prescribe an individualized exercise program that focus on that and kind of address and focus on the limitations, and and also include some support for self-management, right? So for example, how to deal with flare-ups, what to do to manage them. uh so it's kind of moving from, I fix your back, I would try to find out what is going wrong, and more like, I'll help you become more functional, and I'm gonna help you do what you want to do, right? So yeah, this is the idea is, and I think, like, based on the current literature and based on what we know right now, this is the most recommended approach in terms of, exercise prescription. And yeah, I want to just, mention that I think it's, might be a common concern, regarding pain during exercise, whether this is good, bad. And there's actually a review that tried to look at this. So this review that was published, I think it was 2017, they, reviewed papers, like clinical trials with patients with chronic musculoskeletal pain, where, they compared, an exercise program where pain was allowed or even encouraged with, an exercise program where pain was avoided. And what they found was actually, pushing through pain might be beneficial. So they found, graded effect of exercise when pain was allowed. And this has some support from, pain sciences. Uh, Especially because when you think about the patient with chronic pain, they usually have like a highly sensitive pain system. So it's basically a pain system that perceives everything as danger, right? So it's it's highly responsive to nociceptive input. So when you push through through some level of pain, you kind of retrain the system, this highly sensitive a system to kind of perceive exercise as a safe activity, right? As something that shouldn't be painful, and actually doing the opposite. So trying to avoid all the time might can be harmful, right? Like so, if for example, every time your patient feels pain, you ask them to stop, and not do what, uh, to not do what caused the pain. It might actually communicate that pain is equal to harm, right? That if you feel pain is because there's something going wrong, and you have to stop what you're doing. So the idea is that pushing through pain might be beneficial. Yeah, just to, I think this is a very nicely done review as well that I think it's worth bringing up. So it's a review that basically looked at Bayesian facilitators to Bayesian facilitators to exercise adherence among patients with chronic low back pain. I think they had very interesting findings regarding psychological and social factors. And I think these findings align with this perspective of valuing the patient's preferences and kind of uh, uh, yeah, working with them, through a shared decision-making approach. So, for example, what they found is that, when the patient's motivated, when they value exercise, and when they can see benefits from that exercise program, when they clearly understand why they're doing that type of exercise that, was prescribed for them, they adhere more to exercise. When they enjoy doing, what they're doing, when they feel supported, by the provider, when the provider, for example, explain to them, the rationale behind, their decisions, is actually, it's actually beneficial and, increases adherence. Okay, I'm always finishing. I might take only a few more minutes. And yeah, I guess just to finish, I'd like to go through some tips for communication. So we just published this paper in the Journal of Physiotherapy a couple of weeks ago, and we, had a table there where we kind of uh, give like 10 tips for, communicating with patients. And yeah, I'm gonna go over a few ones very quickly. So the first one is about acknowledging uncertainty. So, like I mentioned, we're dealing with a condition where, there's a lot of uncertainty going on, right? We don't know very clearly, what is causing, the patient's pain. So the idea here is that, and I think this is kind of tricky because it's, you sound like more credible if you kind of, use this approach of, being confident and saying that, okay, I know exactly what is going on with you, and I'm gonna fix it, and you're gonna feel better soon, So I think it's quite compelling to go this way, but yeah, it's not the recommended approach, and yeah. And the idea is that, we should acknowledge that, in most cases, pain it's not caused but by a serious a pathology, right? And then the prognosis is usually very positive, and that's pain goes beyond, what is going on in the tissue, right? And our job as providers are to help, patients feel better, move better, and be more functional. Another thing is to, this idea of demedicalizing without dismissing pain. So I think like it's quite common that, patients want to know what's going on, with their body. And it's, many of them, uh, they will rely on imaging and on scans, on MRIs. And I think that, for example, when that happens, and let's say the patient, wants to undergo, an MRI, and they want to know what's going on, I think that could be used an opportunity to kind of, let's say a patient comes up with an MRI result. We can use that to kind of show them, okay, I don't think there's, you know, anything serious going on. So a lot of, those findings are, things that, are pretty common to find even among people who have no pain. Many of those things, are gonna resolve. For example, naturally, some of those things we cannot change. So yeah, let's focus on what we can change, right? Let's focus on, let's focus on you and not on on those imaging findings, basically, right? Emphasize prognosis and function. So again, reassuring that, movement is safe, and the idea that, encourage the patient to gradually increase the activity, and that, feeling pain, it's okay. Feeling some level of pain is okay. And, it doesn't mean that, your condition's getting worse. And the idea is to focus on, increasing function and confidence. And, finally, also, I think this might sound cliche, but I think it's very important, and it's very clear, at least in my practice, that, when we use like a shared approach, when we kind of involve the patient in the, in our decisions, and kind of make the decisions with them, it's very clear that those patients are way more likely to do better and to adhere to, to the treatment that, we propose. So yeah, I think that's really important, like to kind of, identify what matters to them, and then work together with them uh towards, their goals. And, so yeah, that's what I had. So I have, a list of references that I use. Thank you for listening to me, and I would like to acknowledge my team, the back program team. And yeah, happy to answer the questions.
Thank you very much, Samuel, for that great, there we go. Sorry, there's something on the screen. For that great presentation. It was very informative. We appreciate that. I will moderate a few questions. Right now we have about 5 of them, and we have about 10 minutes to finish up. So I think we have some time to go through them. The first question that we got closer to the beginning of your presentation was, do patients that undergo MRIs more frequently due to other conditions also tend to experience more low back pain related consequences?
Say that again, please.
Yeah, do patients that undergo MRIs more frequently, maybe because they have a different condition, do they tend to experience more low back pain related consequences? So they're having scans
Right, but for
because
other
of other
reason.
reason. Do they then tend to have a bit more low back pain experiences?
Yeah, I'm not aware of any study that looked at that, but I would say that no. I think the problem with, undergoing MRI or, scan when they have no specific low back pain is that, you know, many of the findings, maybe, they were there before the pain started, right? And then now you have like this MRI result that says, okay, you have this in your spine. And then I think the problem is when we start attributing, you know, the pain to those findings, which, we kind of start blaming those findings. And I think that's the problem because it's not often the case that, those imaging findings are the causes of the pain. So this leads to, a cascade of issues, you know, uh, like I mentioned, overdiagnosis and overtreatment. And yeah, so I would say that I guess the problem with MRIs, it's kind of uh, blaming, those findings. And yeah, it's not specifically about, doing a scan. It's about, uh, blaming. I think, yeah, the idea is that when the idea of asking a patient to undergo MRI is that you want to kind of find causes for the pain. And then, yeah, once you have a list of findings, you're going to start blaming everything. Yeah.
Yeah, perfect. Okay. The next question that we have is, do you think that the relationship of negative expectations correlates with actual negative outcomes? So do you think that the people that think that they're going to have a poor outcome leads to it, or maybe they were always going to have a poor outcome? So yeah, what do you think about their expectations, a client's expectations for their
Oh,
outcome?
okay. Yeah. So I think, yeah, there's the literature is quite consistent on that, if you, I guess, so the thing with negative expectations is that there's a there's a construct. Maybe you're familiar with that, which is pain catastrophizing, which is the idea that many patients they kind of they think that no matter what they do, they won't get better. That the pain, it's will only get worse. And yeah, this is kind of related to with having negative expectations. And, I think this kind of leads to a lot of, other behaviors. So, they tend, for example, to be less active, right? So they tend to rely more on passive treatments, and be less self-efficacious. So it's kind of, I think it's a combination of factors that kind of explains why people with negative expectations tend to experience worse outcomes, right? I think, yeah, it has to do with their behavior and, and the way they kind of, see their conditions. And yeah,
Mhm.
I don't know
Perfect.
if I answered the question
No,
well.
that's good. Yeah, perfect. I know the on-the-spot questions are challenging. The next one is when a client is working through pain, and this would be pain while they're doing exercise, is there a certain amount of increase in pain that is okay? So, for example, if pain is increasing 2 or 3 points on a pain scale, is that okay? Or is there a certain level of pain that we should be expecting? And then after it gets to a certain point, we would be stopping that exercise?
That's a great question. So yeah, this is one of the limitations of that review. I didn't mention that, but so the papers that they included, they didn't monitor how much pain the patients experience. So it's hard to tell, you know, like, how much is good enough. In my practice, I would say that, 3 to 4, like, 3 to 4 would be okay in a scale from 0 to 10. So the approach that I use in my practice is, let's say, the patient's, doing an exercise, they okay, I felt pain during that. So I usually ask, okay, how much pain from a scale to 0 to 10? Okay, if they say it's 2, okay, let's keep doing it. And if it increases to, I don't know, 5, and then okay, we're gonna try to adapt. We're gonna maybe reduce repetitions, reduce the range of motion, for example. So yeah, so we don't have, I would say they don't have empirical evidence about that, but I would say that 3 to 4 I think it's a reasonable threshold, I would say.
Perfect. Okay. And our last question that we have is, oh, my thing got moved there. One second. Where did it go? Okay, there it is. So, have there been studies tying in the muscles in the pelvic region to pain, such as sciatica pain? So, would the exercises differ depending on which muscles are contributing to the problem?
Yeah, like great question. So there have been some studies that, found association between, like, core weaknesses, and like weaknesses in the core muscles and like pelvic muscles as well. Uh, the thing is, yeah, we have uh, so core. So this whole thing about core exercises and like balance exercises, it's what the literature shows is that it's effective. But it's not that, you know, uh, it's not that much greater than, doing, for example, general exercises. So yeah, it's we kind of, we have this association. We see this association that, usually people with low back pain, they tend to have some issues with their muscles around their back. But yeah, when it comes to treatment, it doesn't translate well. So yeah, so focusing only on that, it's not, more effective than, having a more general approach. Yeah.
Yeah, that's good. No. All right. I would like to take a moment to thank you very much for providing this presentation to the Ontario Kinesiology Association. We greatly appreciate it. And thank you, everybody, for joining us this evening. Once again, this recording will be posted on our website on the Keen section in about 2 weeks for anybody that would like to review. Once again, thank you very much, Samuel, for attending this evening's webinar.
Yeah, thank you very much. Yeah. Have a great
Have a
night.
good night, everybody.
Bye.